আজকে আমরা শুরু করতেছি অপথলমোলজি। ওটার ফার্স্ট টপিক হচ্ছে ডায়াবেটিক রেটিনোপ্যাথি। মোস্ট কমন কজ অফ ব্লাইন্ডনেস ইন অ্যাডাল্টস এজ 35 to 65 ইয়ার্স ওল্ড। এটা প্যাথোফিজিওলজি যদি বলি, হাইপারগ্লাইসেমিয়া ইজ থট টু কজ increased retinal blood flow and abnormal metabolism in the retinal vessel walls. This precipitates damage to the endothelial cells and pericytes. Endothelial dysfunction leads to increased vascular permeability, which causes the characteristic exudates which is seen on fundoscopy. And pericyte dysfunction predisposes to the formation of microaneurysms. Neovascularization is thought to be caused by the production of growth factors in response to retinal ischemia. Classification: patients are typically classified into those with non-proliferative diabetic retinopathy, proliferative retinopathy, and maculopathy. In non-proliferative diabetic retinopathy, there is mild, in which there is one or more microaneurysm. In moderate, there is microaneurysms, blood hemorrhages, hard exudates, cotton wool spots. Soft exudates represent areas of retinal infarction, venous bleeding, or looping, and intraretinal microvascular abnormality, which is also called IRMA, which is less severe than in severe non-proliferative diabetic retinopathy. In severe non-proliferative diabetic retinopathy, there is blood hemorrhages and microaneurysm in 4 quadrants, venous bleeding in at least 2 quadrants, IRMA in at least 1 quadrant. In proliferative diabetic retinopathy, there is retinal neovascularization, which may lead to vitreous hemorrhage, fibrous tissue forming anterior to retinal disc, more common in type 1 diabetes, 50% blind in 5 years. In maculopathy, it is based on location rather than severity. Anything is potentially serious. Hard exudates and other background changes in macula. We should check visual acuity, and more common in type 2 diabetes mellitus. The management is all patients should be optimized for glycemic control, blood pressure and hyperlipidemia, and regular review by ophthalmology. In maculopathy, if there is a change in visual acuity, then intravitreal vascular endothelial growth factor inhibitor should be used. In non-proliferative retinopathy, regular observation should be done. If severe or very severe, consider panretinal laser photocoagulation. In proliferative retinopathy, panretinal laser photocoagulation. Following treatment, around 50% patients develop a noticeable reduction in their visual fields due to scarring of peripheral retinal tissue. Other complications include a decrease in night vision, that is, rods are predominantly responsible for vision in low light conditions. The majority of rod cells are located in peripheral retina. A generalized decrease in visual acuity and macular edema. Intravitreal vascular endothelial growth factor inhibitors should be used, often now used in combination with panretinal laser photocoagulation. Examples include ranibizumab. Strong evidence base suggests they both slowly there is slow progression of proliferative diabetic retinopathy and improved visual acuity. If severe or vitreous hemorrhage, then vitreoretinal surgery should be done.